Imaging and Mullerian duct anomalies. Before we talk about it, why is it even important talking about Mullerian duct anomalies? Well, anomalies are quite common in the female internal genitalia, and these anomalies can actually be a normal variation in the anatomy, or these can actually be a true anomaly. So, it is important for us to differentiate them. Not only because of that, diagnosis is important because there are certain anomalies with certain sets of complication, and also there are certain anomalies in the Mullerian duct which benefit hugely from the treatment. Even in the incidence point of view, it is quite common. According to one study, it occurs and has high as 7% in the general population, and in the females presenting to the outpatient department with history of both infertility and miscarriage, the incidence shoots up to 25%. Before we talk about the Mullerian duct anomalies, we have to know about embryology in a brief way. So, after conception, in the zygote, there are two ducts, the Wolffian duct and the Mullerian duct, which is Wolffian duct is the mesonephric duct and the Mullerian duct is the paramesonephric duct. In a female, there is no Y chromosome. Since there is no Y chromosome, there is no SRY gene. Since there is no SRY gene, there are no androgens, so proliferation of the Wolffian duct doesn't occur. And also, there is absence of the anti-Mullerian hormone, due to which there is nothing to stop the Mullerian duct. So there is proliferation of the Mullerian or the paramesonephric duct. So at around fourth week of gestation, two Mullerian ducts form on either side of the midline. In due course of time, there is gradual medial migration of the Mullerian duct, and around sixth week of gestation, they move very close to the midline. At around eighth week of gestation, it is associated with fusion of the Mullerian ducts from the either side. With the fusion occurs from the caudal to the cranial direction, which is important to know for classifying the Mullerian duct anomalies, and also to understand it. At around 12th week of gestation, there is a gradual resolution of the septa which has formed, and by the end, at around 36 weeks of gestation, a normal uterus which is seen after the birth is formed. Well, this is what happens when all the steps of Mullerian duct in the embryology occur properly. What if it doesn't occur? The first step is the formation of the Mullerian duct. And what if it doesn't occur? It leads to Mullerian duct agenesis, and this agenesis can be unilateral or bilateral. If it is unilateral, it leads to unicornuate uterus, or if it is bilateral, it can lead to Hemarcate syndrome or uterine vaginal or the cervical agenesis, or if it is incomplete, it can lead to hypoplasia. So let us assume that the Mullerian ducts are formed. What if the next step in the process, that is the fusion of the Mullerian duct, doesn't occur? It leads to fusion anomalies, which are nothing but the bicornuate and the uterus didelphys. What if the fusion has occurred normally, but the next step, which is the resorption of the septa, didn't occur? So non-resolution of the septa, it leads to the septate uterus. And what if all these steps occur normally? It leads to the formation of the normal uterus. So since we are talking about the normal uterus, we have to know about the normal uterine measurements. So as depicted in this table, the length of the uterus is slightly larger in the neonate when compared to the pediatric population, basically owing to the due to the effect of the maternal hormones onto the uterus of the neonate. However, from the pediatric age group to the reproductive age group, there is gradual increase in the length of the uterus. So does the uterus to the cervix ratio, which is 1:1 in the pediatric population, but gradually, as the age increases till the reproductive age group, the uterus to the cervix ratio gradually increases. In the postmenopausal group, as we all know, there is a dip in the uterine length as well as the uterus to the cervix ratio. Since we're talking about the Mullerian duct anomalies, we have to know what are the classification systems which were used or which are used for classifying them. So there are many classification systems for Mullerian duct anomalies. The oldest one dates back to 1946, which is the Kaufman's classification. We do not use this classification anymore. After this, there was the very famous American Fertility Society classification in the year 1988, which was used for many decades, which was a very simple classification. However, in the year 2013, the European Society of Human Reproductive and Embryology (ESHRE) classification was created. And in the year 2016, the American Society for Reproductive Medicine classification was created, which was the version 1, which was further updated in the year 2021. So the first classification system was the Kaufman's classification system, as we discussed. However, we are not going to talk about the Kaufman's classification system simply because this classification system is not used anymore. The American Fertility Society classification, which was launched in the year 1988, was very famous for its simplicity and was used for many decades. AFS classified the Mullerian duct anomalies into seven classes. Some of the classes are again divided into subclasses. However, we are not going to discuss about AFS as well in detail because we do not use this classification anymore. However, what we have to remember is that the American Fertility Society classification is very important because it forms the cornerstone of the classification system what we use right now. So this classification system was used for many decades. It was quite simple. It was accepted widely. So why was there a need to create a new classification system? Well, although the acceptance rate of the American Fertility Society classification was very high, it still had some serious limitations. One of the important ones is that it classified anomalies into compartments, and according to the AFS, these compartments do not overlap. However, in reality, this doesn't occur. There is a lot of overlap between each anomalies as seen clinically, and due to which certain anomalies which we see in day-to-day life could not be categorized into any of the class of the AFS, which makes it clinically not much useful. So to overcome all these, a new classification was created in the year 2016, which was the European Society of the Human Reproductive and Embryology (ESHRE) classification. So, before we talk about the ESHRE classification, we have to know about few terms such as the intercornual angle, intercornual distance, external indentation, and internal indentation. So, in this image, we can see a normal uterus. We can see the uterus, the body, the fundus, the cervix, and the normal fallopian tube and the fimbriae. So, so the junction between the fallopian tube and the uterus is the cornu. We can see the right cornu over here and the left cornu over here. So if we draw a line which joins the two cornu, it becomes the intercornual line. And if we draw a line perpendicular to the intercornual line in upward direction, touching the fundus above, this line is called as the external indentation. And if we draw another line perpendicular to the intercornual line but in the opposite direction towards the internal indentation, this line is nothing but which measures the internal indentation. And if we measure the angle present between the two cornus as depicted in this image, this becomes the intercornual angle. According to the American Fertility Society classification, it classified the anomalies like the septate uterus or the arcuate uterus based upon distinct numbers. Like if the internal indentation, if it is less than 1 centimeter, then it is arcuate uterus. If it is greater than 1 centimeter, it is the septate uterus. However, according to the ESHRE classification, they believed that we cannot keep an absolute numbers to classify the Mullerian duct anomalies simply because the size of the uterus differs from each female. So they believe that the anomaly should be measured in terms of the uterine wall thickness because it is unique for each female uterus. So we have to know how we measure the uterine wall thickness. So the best way to measure the uterine wall thickness is in the 3D ultrasonography or the MR. However, if it is not available, we can use a 2D ultrasound as well. So in these 3D ultrasound spots, we can, in this image A, we can see the 3D spot of a normal uterus. Here we can see a line which is represented by 1. This line is the intercornual line, and the line is drawn perpendicular to the intercornual line towards the external indentation. And this measurement is the uterine wall thickness. In the image B, which depicts the arcuate uterus, we can see the similar line, the intercornual line, and the line which is drawn perpendicularly towards the fundus. This becomes the uterine wall thickness, and the line number 2, which is drawn perpendicularly inferiorly, becomes the internal midline indentation. The same thing is depicted in figure C, which is the image of the septate uterus, and in the figure D, which is the image of the bicornuate uterus. The preferred way to measure it is the 3D ultrasonography or the MR. However, due to unavailability, we can do it on 2D ultrasound as well. So basically, in 2D ultrasound, in this ultrasound spot in which the curvilinear probe was used, and the probe is placed sagittally on the pelvis, and we can see the uterus present over here. First, we have to find the fundus, which is depicted over here, and we have to find the cervix, and we have to find a point which is midway between the fundus and the cervix, which is roughly over here. And we have to draw a line anteriorly and a line posteriorly. And we have to take a mean average of the two measurements, the anterior line and the posterior line. And the average becomes the uterine wall thickness, the measurement of the uterine wall thickness. So based upon this knowledge, now we are in a good position to talk about the ESHRE classification system. The ESHRE classification system divided the Mullerian duct anomalies into anomalies of the uterus, anomalies of the cervix, and anomalies of the vagina separately, contrary to that of the American Fertility Society classification. And what is peculiar about this classification is the inclusion of a class for normal uterus, which is the U0, the normal cervix, the C0, and the normal vagina, the V0. So, why was there a need to incorporate normal uh, anatomy into the Mullerian duct anomaly classification? So it is basically done to signify that there are certain anomalies in which uterus can be normal, but there can be abnormality of the cervix or the vagina, which can be depicted by the usage of the class U0. So the first class of Mullerian duct anomaly, according to the ESHRE classification, is the dysmorphic uterus. The dysmorphic uterus incorporates all the cases of the Mullerian duct anomalies which have normal uterine outline. However, the shape of the uterine cavity inside is abnormal and there is no septa as well. This U1 is again divided into T-shaped, infantilis, and others. The basic difference between the T-shape and infantilis is the ratio of the uterus to the cervix. If the uterus and the cervix is two-third and one-third, that is two-third of the uterus and one-third of the cervix, it becomes T-shaped. If it is inverted, that is one-third of the uterus and two-third of the cervix, then it is called the infantilis. And all the other anomalies which do not which are not classified into U1A and U1B are included in U1C. The second subclass is the U2, which is the septate uterus, which is again divided into partial and complete. Similar to U1, even in the septate uterus, the shape of the uterine cavity outside is normal. However, uterine outline is normal. The shape of the uterine cavity inside is abnormal. So first, to diagnose septate uterus, we have to see the external indentation. And to diagnose a septate uterus, the external indentation should always be less than 50%. Now, if it is less than 50%, now we should look at the internal indentation. If the internal indentation is greater than 50% of the uterine wall thickness, then it is called as septate uterus according to the ESHRE classification. And if this internal indentation is completely dividing the uterine cavity, it belongs to UTB, the complete septate. And if it is not completely dividing the uterine cavity, then it belongs to U2A, the partial septate uterus. So after the septate uterus, the third class according to the ESHRE is the bicorporeal uterus, which is also interesting because according to the American Fertility Society classification, the fusion anomalies are two, which is the bicornuate uterus and the didelphys uterus. However, the two fusion anomalies are included in one class according to the ESHRE classification system. The bicorporeal uterus, basically it includes all cases of the fusion defects. And for to diagnose bicorporeal uterus, we should have an external indentation, and this external indentation should be greater than 50% of the uterine wall thickness. And what you have to remember is that this external fundal indentation sometimes can completely divide the uterine corpus, in some cases including the cervix and the vagina. The U3 bicorporeal uterus again divided into partial, complete, and bicorporeal septate. In partial bicorporeal uterus, it is mainly characterized by the external fundal indentation, partially dividing the uterus corpus above the level of the cervix. However, in complete bicorporeal uterus, the external fundal indentation is completely dividing the uterine corpus up until the level of the cervix, sometimes even the cervix and the vagina as well. However, the new entity, the bicorporeal septate uterus, was introduced according in the ESHRE classification, which is defined as the presence of the external uterine fundal indentation, which is greater than 150% of the uterine wall thickness, and the U4, which is the hemiuterus. And the hemiuterus, it incorporates all the cases of the unilateral formation of the uterus. Basically, it is a formation defect. The necessity to classify hemiuterus as a separate class other than that of the aplastic uterus is due to existence of a fully developed functional uterine hemicavity. As being depicted in this image, U4 hemiuterus is again divided based upon the presence of the rudimentary cavity. If U4A with rudimentary cavity and U4B without rudimentary cavity. And again, these can be subclassified based upon the presence of functional tissue or not. Uh, and as we all know, if presence of rudimentary cavity which is not communicating with the presence of functional tissue is much more dangerous, because the risk of endometriosis or the ectopic pregnancy and dysmenorrhea increases a lot. So, even after all this, in the year 2090, a study performed by Ludwin et al. On septate uterus, they found that this white circle depicts all the population with septate uterus, and the red circle depicts all the population who are diagnosed with septate uterus according to the ASRM 2016 version 1 criteria. And the circle in the yellow depicts the population who are diagnosed with septate uterus according to the ESHRE criteria. So we can clearly see that there is gross underdiagnosis if we use the ASRM 2016 criteria. However, there is gross overdiagnosis if we use the ESHRE criteria for diagnosis of septate uterus. So in general, there's a lot of gray zone which is present. And not only that, there were quite a few classifications for Mullerian duct anomalies, and due to inadequacy in exposure and due to rarity of Mullerian duct anomalies in clinical practice, it led to quite a bit of confusion, and due to which there is delay in diagnosis, sometimes even misdiagnosis, which led to wrong treatments. And also to improve the communication between radiologists and non-radiologists, there definitely was a need for a new classification system. So there comes ASRM 2021 to our rescue. The American Society of Reproductive Medicine updated their original classification in the year 2021. The main advantage of ASRM MSc 2021 is that they use the basic template of American Fertility Society, which was quite popular classification, which was used for many decades, as discussed for Mullerian duct anomalies, and they improved on it. They no longer used numbered terminologies. For example, if I say U2, C2, V2, very few of us will remember what is U2, V2, C2 according to the ESHRE classification. Instead of that, U2, C2, V2, if I say it is a septate uterus with a double normal cervix and longitudinal vaginal septum, it makes much more sense. They even made a web application so that it can be available at any time on our fingertips. They even standardized the terminologies better than the XHRE classification. However, the simplicity of the line diagrams was kept in the ASRM classification. And similar to the SHRE classification, the anomalies of the cervix and the vagina was also included with the uterine anomalies. And it stated that, which was very important, the Mullerian duct anomalies are not distinct anomalies. They're not watertight compartments. There, it is a spectrum of Mullerian anomalies which show a lot of overlap. So the clinical presentation of each anomaly can be quite different than what is present in the classification system. So there is a lot of overlap between the categories, and the classification system is kept open. That is, it is not considered as complete because there are certain variations and anomalies which are yet to be discovered, and it is also mainly aimed at teaching the resident. So these are all the goals of the ASRM MSc 2021 classification as we discussed earlier. When we open the ASRM MSc 2021 web tool, it has many sub pages. The anomaly classification is basically divided into six sub pages, which include the variant sub page, the similar to sub page, the presentation sub page, the imaging sub page, and treatment and classification sub page. Basically, the variant sub page includes all the drawings that depict the potential variations for each anomaly within the category. So, for each anomaly depicted, the possible variations for the uterine, cervical, and vaginal portions are noted. However, in the similar to subpage, it mainly shows other anomalies that are similar in presentation, examination, and imaging. So, basically, to help providers refine their differential diagnosis. So if we click on any anomaly listed in the similar to section, the user will be brought to the main page for that similar anomaly to explore it more. And according to the presentation subpage, it includes all the clinical information available for each category of anomaly. Basically, the goal is to educate the user on typical presentation and also the other similar anomalies that may present in the same way. The presentation is again divided into based on the symptoms, based on examination, also that all the set of differentials possible for the condition which can present with similar presentation. The next subpage is the imaging subpage, which describes the best screening tool, the diagnosing strategy involved, and the findings for an anomaly category. It also includes the examples of pertinent selected anomalies in basically three imaging modalities: the MR, the HSG, and the ultrasonography. And the treatment subpage is again divided into medical treatment, dilatation treatment, and surgical treatment option. It basically depicts all the treatment options available for that particular Mullerian duct anomaly. So this is the American Society of Reproductive Medicine Mullerian Anomalies Classification 2021 का web page tool. The link for which is given in the description below. So to depict what I said earlier, these are all the Mullerian duct anomalies. If I click on any Mullerian duct anomaly, for suppose I'm clicking on the Mullerian agenesis, it shows the subpages of that particular anomaly. As I already said, there are six subpages available for all the anomalies. If I click on the variant subpage, it shows all the potential variations available for Mullerian agenesis. And not only that, it also depicts the possible variations for the uterus, possible variations of the cervix, and possible variations of vagina seen in Mullerian agenesis. It also has a separate section which is called as the known as section, which includes all the names or the synonyms synonyms which are used for Mullerian agenesis. For example, for Mullerian agenesis, we call it Mullerian agenesis, the MRKH syndrome, or the Mayer-Rokitansky-Casterosis syndrome, or the agenesis, vaginal agenesis. However, among all these synonyms, one of the synonym is underlined, basically to signify that that is the preferred uh, name which should be used to describe that anomaly. And the second web page is the similar to web page. And if I click on the similar to web page for Mullerian agenesis, it shows all the anomalies which show similar presentation, examination, and imaging findings. So in vaginal Mullerian agenesis, the similar presentation can be seen in androgen insensitivity syndrome, distal agenesis, transverse vaginal septum, cervical agenesis, and imperforate hymen. And if we go to the next sub page, the presentation sub page, it includes all the clinical information for Mullerian agenesis. Basically, the goal of this presentation sub page is to educate the user on typical presentation and other similar anomalies that may present in the same way. It is again divided into symptoms, examination, and differentials to for possible differential diagnosis for the Mullerian agenesis, which can have similar presentation as depicted. So the next subpage is the imaging subpage, which describes the best screening tool for Mullerian agenesis, which is the ultrasound or the MR, the best diagnosing strategy, which is the MR according for Mullerian agenesis, and also the findings which can be found in these imaging tools. And the next subpage is the treatment subpage, which shows all the available treatment for that anomaly. For Mullerian anomalies, Mullerian agenesis, the treatment is divided into medical, dilatation, and surgical. It shows all the surgical medical treatment available for that particular anomaly. And the last subpage, which is the classification subpage, and if you click on it, it just takes back to the main classification subpage of the ASRM MAC 2021 classification. So up until now, we talked about Mullerian duct anomalies. Why is there a need to learn about Mullerian duct anomalies, the embryology in brief? We also talked about the various classification systems available, the AFS, the ESHRE, the ASRM. Well, first of all, what all investigation modalities which are available for MDs? So broadly, the investigation modalities to evaluate Mullerian duct anomalies can be divided into three. That is the hysterosalpingography, the ultrasonography, and the MR. The hysterosalpingography can be conventional using fluoroscopy, or we can use CT as well. The ultrasound can broadly be divided into 2D sonography and 3D sonography. And again, in 2D sonography, it again can be classified based on whether we are using a medium or not. If we are using a medium, what medium are we using? Are we using a saline or contrast? And without a medium, it can again be classified into transabdominal sonography and endovaginal. As discussed earlier, the best imaging modality available to evaluate MDA is the MR or the 3D ultrasonography. So, is it even possible to differentiate between septate and bicornuate uterus just on HSG? Well, to answer this, to some extent, yes, it is possible to differentiate them. But how much extent is it possible? So we talked about the intercornual distance and intercornual angle and how do we measure them. For intercornual distance, the number is fairly simple, which is 4 centimeter. If it is less than 4 centimeter, then very high chance that it is septate uterus. If it is greater than 4 centimeters, very high chance that it is bicornuate uterus. The same thing cannot be said for the intercornual angle. If the intercornual angle is less than 75 degrees, it is more likely to be septate uterus. If it is greater than 105 degrees, more likely for it to be bicornuate uterus. But the problem lies with the angle if it is between 75 to 105 degrees. So there is a gray area of 30 degrees for which The answer can be either. It can be septate uterus. So let us see it in the form of few examples. Oh, in this HSG spot, when the intercornual angle is measured, it shows around 65 degrees and the intercornual distance is around 2.2 centimeters. So this is more likely to be a septate uterus. In the next HSG spot, we can see the intercornual angle when measured. It is around 110 degrees and the intercornual distance is 4.2 centimeters. So this HSG is very highly likely to be of a bicornuate uterus. But what if in this HSG, the intercornual angle is around 92 degrees and the intercornual distance is around 3.7 centimeters? Well, the intercornual distance of less than 4, it is likely to be septate uterus, but the intercornual angle is in the gray area of 75 to 105 degrees. So we cannot actually tell whether it's a septate or bicornuate uterus. So to some extent, we can differentiate between septate and bicornuate uterus on HSG, but it is not 100% foolproof. So to summarize it, the differences between septate and bicornuate uterus, as we already talked about on HSG, if the angle is less than 75 and the intercornual distance is less than 4, highly likely for it to be septate uterus. If it is greater than 105 and greater than 4, then it is bicornuate uterus. And for indentation, the rule is we should always measure the external indentation first. If it is less than 1 centimeter, it can be normal, it can be septate. Now we should measure the internal indentation. If the internal indentation also is less than 1 centimeters, it is normal or arcuate uterus. However, if the internal indentation is greater than 1 centimeters, then it is septate uterus. It is opposite for bicornuate, in which obviously we measure the external indentation first, and if it is greater than 1 centimeters, then directly it is bicornuate uterus. It is similar for ESHRE as well, but the only difference is that instead of using an absolute number, they measure it in proportions to that of the uterine wall thickness. That is, if the internal indentation is greater than 50% of the uterine wall thickness, then it is septate uterus, and if the internal indentation is less than 50 and the external indentation is greater than 50% of the uterine wall thickness, then it is bicornuate uterus. The treatment and prognosis of both of them is given here. And in the next table, the basic difference between diadelphys and bicornuate is that in diadelphys, as depicted in this image, we can see two separate endocervical canals which open into two separate endometrial cavities, and there is no communication between the two horns. However, in bicornuate uterus, it manifests as two partially separate uterine bodies, and obviously there is an external indentation which is greater than 1 centimeter according to ASRM and greater than 50% of the uterine wall thickness according to ESHRE criteria. And both of them have fairly good prognosis as well. So the source of the above slides is mentioned on the screen. You can go to the mentioned links for further reading. So in this video, we talked about Mullerian duct anomalies, its imaging features, why is it important for us to learn about Mullerian duct anomalies. We learned briefly about the embryology, the classification systems which are available for Mullerian duct anomalies, their advantages, their disadvantages. We also learned about the difference between certain anomalies and also how to use the American Society of Reproductive Medicine Mullerian Anomalies Classification 2021 webpage tool. Hope this video helped to understand Mullerian duct anomalies better. Thank you.